Hey everyone, like I said, this week we're going to be doing chapter 2, 3, and 5. So this is chapter 2. This is the screening component that we were just talking about. This is the assessment component of everything. So um, information wise, a lot of this may seem like a repetitive motion, repetitive information or anything like that. So it shouldn't be too long to get through, but just pay attention to the more common themes of everything here. So um, with health evaluation, obviously, what are we looking for here? Overall quality of health, but really, is there a presence? Is there any signs or symptoms or anything related to a particular disease? Is there anything that you can uncover, almost detective wise, for, like it says there, likelihood or unexpected cardiovascular events that are related to exercise or physical activity? Because this is about the fitness component of it. So is it that you're able to see that, but you're assessing it, you're trying to find information, and that's where we're using questionnaires and we're collecting data from specific tests to be able to determine what the evaluation is, what the makeup of everything is, and then does this person really need to see a health specialist? Do they need to stay in your care or some other aspect? All right. So with minimum screenings, and we've kind of hit on this in class a little bit, but if you administer the PAR-Q, but now they have a PAR-Q Plus that has the 7 additional questions that are yes and no, which is what we used to, see as just a regular base. But now the PAR-Q Plus actually has, it's almost like they've taken the PAR-Q and combined it with a health history questionnaire, and you fill out a bunch of additional background information that'll help the screener, whether it be a nurse, whether it be us as exercise specialists, and they will be able to determine what the findings are based on the yes and no answers of the first part of the PAR-Q. Also, if you're going to be doing any evals, even before exercise even takes place, you need to get them to sign off on an informed consent. And just remember that an informed consent is basically you are laying out everything for someone. You can't have any hidden agenda inside of it. And you are signing off that you are going to treat everybody fairly, you're going to treat everybody safely, correctly, ethically, morally, and that you are laying out all of the details, and that the person who is taking the eval, screen, assessment, whatever they're doing, they're signing off that they understand the risks and the associated consequences that may come with it. If obviously, if there are any, may not be, but you understand what we're getting at. You're gonna evaluate exercise patterns of the past 3 months. So from 3 months before to now, when you're doing it with everybody, you want to see, were they active, were they not active, how much activity, what types of activity, things like that. Signs and symptoms of classifications of disease risk, so that you can determine what level they're at. Coronary disease risk as well. Is there anything that's indicating that there is any issues with the heart? Coronary disease, leading to eventually cardiovascular disease, and we all know what the outcome of that is. So, that's going to be where medical clearance is going to have to be needed, and you're going to have to figure out how risky this person would be is it if you were the only person supervising them. All right, so there's your PAR-Q plus. There's the 7 yes and no's. There's also follow-up questions, and like it says here, if there's a yes for any follow-up questions, it's going to be professional consultation. So it just depends on who that is going for. The eParmed X, that's a that's going to be filled out by the individual, but it also needs to be that's basically almost a referral that you're going to be giving, so that that person takes that with them to the medical professional that is going to eventually do the sign up. So whether it be their primary care physician, whether it's a cardiologist, whether it's it doesn't it could be a neurologist, it could be it could be any sort of doctor that or physical therapy, but I would say more of medical doctor base for that. Okay, so those are the two that you can use there. And I'll give you the, you can look online for those, but I'll also put the examples of those up on our website, on our Blackboard site. So medical history questionnaires, one of the things, I mean, really the red little square basically sums it up. These medical history questionnaires are going to give you absolute and relative contraindications, and we all know that contraindications are things that are identified that you cannot perform certain tasks because of specific reasons for that. A perfect example is someone who is, a month past knee surgery, but they're still not cleared for movement past, say, 75 degrees. You're hoping that you can get, higher degrees of range of motion with that knee as you get longer into that, treatment, but a contraindication would probably be no squatting, no leg extensions, unless of course the physical therapist or the surgeon think that it's okay. Okay, so it just depends on where they're at treatment wise. Do they have any do they have any setbacks? Do they have any pitfalls? Things like that. So, with this is going to determine your medical clearance. It's going to show any signs, symptoms of any diseases, but it's going to give you also some background on them. The first, I kind of went reverse order here, but it's also going to give you personal and family medical history. This also is probably going to show you like some like what they do for a living too, like what their employment status, like employment is, like if they're, it doesn't matter if they're a garbage truck worker, if they're a custodian, if they're a clerical worker, a lawyer. It doesn't matter. It'll answer all those style of questions. So when we talk about, if you go back, if you look right, where was it? Right here. This part, analyze coronary disease risk factors. When we go back to here, these are things that we can control versus uncontrol. So modifiable, we're talking about cigarette smoking, hypertension, high blood pressure, diabetes, and that's particularly type 2, just because that's usually adult onset, but obviously don't underestimate type 1. Dyslipidemia, so not imbalanced fat lipid profiles. So you're talking about cholesterol, triglyceride levels, those types, HDLs, LDLs, VLDLs that are going to be out of whack in some way, shape, or form, and then total cholesterol as well. There's your obesity, and then their activity level, so they're probably not moving. So those are all modifiable. We can reverse, not that we can reverse, let's be clear on that. We can have people stop smoking. Damage done in smoking has already been done. We can try to get people off of hypertension medication, things like that. That's modifiable. Diabetes, again, we can modify that off of medications, potential limiting of insulin needed, things like that. Modifiable, again, dyslipidemia, that could be dietary change, exercise change, a combination of both. It could be, cigarette smoking, again, alcohol consumption. There's a lot of those things that go with that. And obesity plays a part in all of those, and so doesn't, an inactive lifestyle. But unchangeable, age and family history, or, genetics, family history, those are things that are not going to be able to be changed because it's embedded in your DNA. And then age, you can't get over the fact that you're going to get 1 year older every year. So, with disease risk classifications here, it used to be where, like it says here, there used to be a bunch of criteria that you used to have to meet that would basically, say you were low, moderate, and high risk. But now, like it says here, it's based on current exercise habits and signs of 3 diseases, cardiovascular, renal, and then metabolic. Okay, so if there's anything associated with that, then we know that you're showing higher symptoms if you have all 3. You're showing no symptoms if you don't have anything going on with any of those. Okay, and so you have a score system, and this is, it says here, it's used to estimate the 10-year risk of a first fatal cardiovascular disease. This has been something that they associated with in the European countries, and it's something that, like it says here, you need to know those things that are below. total cholesterol. So what need to total cholesterol be, is it under is it under 200? Is it 200 to 240? Where is that range? But under 200 is optimal. Let's see, systolic blood pressure. Obviously, there's 120 over 80 is the that's what generic. 115 over 75. There's lots of different scores that we can look at in terms of but really, if you can keep that below 120 over 80, we're looking to be in some pretty good numbers there. Smoking status, I mean, that's as simple as it gets. Are you a smoker? Are you not a smoker? Have you smoked previously? How long has it been since you have? Those are really what it comes down to. And then sex, meaning male, female. So those are the aspects that we look for in that. So in looking up, more about the score system, like it says here, there was a database that was collected for the score system, and it was based on, it says here, based on 12 European cohort studies. So they did large group studies. So within those 12 studies, there was approximately 250,000 people, patient people, their data was collected. 3 million person years of observation worth. So there's 300 million years of observation. That's a lot, based on that 250,000 people. And then during that time that this was run, like it says in this little guidance here, it said 7,000 fatal cardiovascular events were recorded during that time frame. And it's just, that was how it was found, and that's how it was created, so that, we could adjust based on high and low risk factors. So, and then, like I said, we're taking into consideration gender, age, total cholesterol, systolic blood pressure, and then smoking status. So, and then there's a chart based on all of that. So I will actually put this up for you guys to see, but you can see that, if you look at certain parameters, where were you? Where was the cholesterol levels? How high did certain things go? Were you a non-smoker versus a smoker? Were you male versus a female? So it's really quite interesting how this kind of came up. But what I'll do is I'll put this up on Blackboard as well, and then put the website that it came from, because this is actually really interesting how you take a lot of information, you put into this really simple graph, and it really shows you, like, okay, this is where you're at, this is what you're doing, where's your relative risk. So it's really pretty interesting. So if you get any questions based on this, it's going to be from this slide, but also take a look at the infographic that's going to be on your on Blackboard as well. So for lifestyle evaluations, how are they living? What are they doing daily? What is it that's causing them to not be able to complete their exercise? Okay, so some of the things that we have to ask ourselves is what are some examples of aspects you might discover? What are certain things that you're going to find? Those are things that what are examples would be something like, well, what are you going to find? Are they a very active worker? Are they are things like landscaping, construction, all like the very hands-on demanding jobs? Those are things, are we finding that those people are, even though they're maybe healthy, or maybe they're unhealthy, even though they're working constantly with their hands and their upper and lower body all day long, well, they're not doing, they're doing work activity. So there's a lot of variation to that. So we have to think of those examples of what is it that's causing these issues. Okay, so there's your informed consent. We pretty much went over that being a binding contract. All right, you need to have a signature. Minors have to have parents involved with this. There it is again: procedures, risks, benefits. It's confidential. No one's going to know anything about you and your scores, and it's voluntary participation. And the one thing that you are allowed to say during at any point in time as the trainer or the trainee is, "I'm done." Okay, you cannot tell somebody, "We'll keep going." The only time that needs to happen is, well, even then, it's cardiac stress testing can be a little tricky because it's medically supervised, and there's so many devices hooked up to these individuals that they can see when something becomes drastic enough that they have to call termination. But with a stress test, you're going to go beyond discomfort, and it's still voluntary, but at the same time there's still some involuntary, where you're going to have to push and basically stress the body to a max level. So it's really really an interesting thing about that versus like just generic exercise. But informed consent, again, it can be a legal document. Certain facilities require you to sign it, and it's going to be put into a file, and it'll be placed in that direction. So it can, if it comes down to it and something happens, it's a way to kind of cover your behind, so that in court you're not going to get yourself into trouble because of that. So in terms of clinical testing, really, we physical examinations, that's where the EPAR MedX Plus comes into play. We're looking for signs and symptoms. Medical professionals taking care of that. Same thing with medical professionals doing blood chemistry. You're getting your blood draws done. You're looking for all of those parameters there, and then you can EKGs, echocardiograms, chest X-rays, pulmonary functioning. You're gonna that would be a respiratory that would be more like respiratory therapist versus like us as an exercise professional. So they would actually physically go, inside of a hospital, they have respiratory techs that would do this, or respiratory specialists. And then, there's your comprehensive your blood chemistry, besides just these factors here, besides just blood glucose, cholesterol, and triglycerides. Depending upon what's going on, there can be more, and potentially there should be more, depending upon what you have going on with you. There's your GXT, your grade exercise test. This is your true stress testing. This is really a way to determine many different things in one shot. Ischemic heart disease. Are we having issues with the heart functioning correctly? We can see that there. The problem with a stress test, though, is like it says, if there's contraindications already present, then probably not going to be the best thing for them. But that's why working with trained professionals is going to be optimal, because it's going to be it's very clinical at that point. So if anybody is looking to go beyond just the strength and conditioning personal trainer route, or those, and even working in a physical therapy and chiropractic offices, this is going to be severely clinical, and it's going to be one of those things where you're going to be surrounded by other nurses and other staffing, plus a doctor may be present at that time. So it's an all hands on deck team approach, so that nothing happens to the individual, because they're going to be pushing hard. The one thing about this GXT is it's going to provide you a scoring level for how fit you are cardio respiratorily. So in that right there, low CR fitness levels, cardiorespiratory, their fitness levels, it can be a strong predictor for CVD or cardiovascular disease. Okay. And then basically what we're saying here is that if you can get scoring from the GXT, you can kind of it's a baseline for what your aerobic conditioning should be for that person. So low level, low scoring would be low level training. Higher scoring could be higher training, or what is necessary for that person. As far as blood pressure goes, there's your resting blood pressure there. You can systolic, diastolic, your systolic contractive pressure, your diastolic meaning your relaxation or refilling pressure. Pulse pressure is the difference between your systolic and diastolic. And the problem with pulse pressure is the closer it gets to zero, basically if there's zero, as if you just say that your blood pressure was 120 over 120, that means that the heart doesn't have a higher contractility versus a relaxation, so the heart won't pump because there's no difference in pressure. Okay, that's why systolic has to be higher. Okay, normotension is normal. Normal blood pressure. Pre-hypertension is before you get to the hypertensive state, but again, it could be a indicator that things are changing for you. Okay, and then obviously people can get put on specific blood pressure medications that you know, have certain purposes, and then some people can only take certain types of them. But if you were to look, if you were to go and just, go to your doctor and look, or even if you go online and just take a look at what certain things do, you can, like for example, diuretics. What diuretics, they're, what do they call? The generic name is water pills. Help they basically help the body get rid of a large quantity of sodium or salt in your system, and it helps with controlling blood pressure because higher levels of sodium can potentially be an enhancer for higher blood pressure, which is obviously what we don't want. Okay, if you look at things like ACE inhibitors, and so it basically stands for angiotensin converting enzymes, and so ACE inhibitors, what they'll do is they'll help you produce less angiotensin. And what angiotensin can do is basically be it's a narrowing, it's a constriction, it's a constricting. So basically what you're doing is you're tightening up the blood vessels, and so therefore it's going to create issues with something like your kidneys. So then therefore if your kidneys are blood narrowing to the kidneys is not going to help with waste removal and filtration. So that in turn causes a raise in blood pressure, and then therefore because you have to push more blood through a narrower tube, it's like trying to fit like a pool size of water through a straw. You have to increase the pressure to get it through. So ACE inhibitors will, they'll help lower blood pressure by helping to vasodilate, and that will help with that. So if you ever are in question about that, yeah, just go on and type in, blood pressure medications, and you'll get a list. Especially if you go to, I think it's heart.org is really good about this, and they give you a breakdown of them all. They give you the names of everything. They give you the generic name, common name, so you can really look deeper into that if you really wanted to. But like I've told classes before, you need to be you're not a pharmacologist. You're not going to have the ins and outs of every single medication that's out in the market. So the best bet is to either have a website that's available to that's reputable and that knows a lot about those particular things, or get a medication book that you can keep on your bookshelf so that if you ever have a person who's taking certain things, you know what that medication does to their system and what exercise is going to do to that system depending upon that. All right. So this is when we're looking at LDLs, for example. All right, so your LDL cholesterol, goal-wise, we want it to be right here. We want it to be under, we want it to be under 100. Okay, anything higher than 100, you can see that we're going to cause, us to have some risk factors here. So that's the goal, is that if we can get our LDLs to be below 100, it can help with keeping ourselves from increasing the risk of, CVD. All right, so that's one of them. For HDLs, it's 60 or above is optimal. Really, the goal for being in health, even though above 60 is the best, is clinically is above 40 milligrams per deciliter that we want to have at that point. So we're looking at it from that standpoint there. All right, and then total cholesterol, we want it to be under 200. All right, blood pressure wise, we've done a lot of blood pressure. As hopefully you've done it before I was here, but you should be doing blood pressure assessments. And I'm not talking about doing blood pressure manually. Okay, we want to be able to use our sphygmomanometer. We want to be able to use our stethoscope. We want to be able to practice and listen and hear all of those sounds. So next week when we do have class, we are going to be working with blood pressure assessments. So we have to be able to constantly practice that, because sometimes automatic ones are not a one-size-fit-all, and using a regular blood pressure cuff and a stethoscope is going to be your best alternative. So the more you do it, the more you have a better opportunity to hear different different sounds from different people. So these are this is the technique here. So we'll go over these a little bit more in depth, but really, If you know you have a hypertensive person and you see that their previous blood pressure was, 200 over 110, you're going to want to pump that up pretty high. Um, so if it's really that high, you want to be, 220, 240, that you pump it up to before you release it, because you have to build up that pressure so you can hear the flow of the blood eventually, okay? So with automated, again, just making sure that it does fit on the arm appropriately. They have done a nice job of making the cuffs better. They have Bluetooth cuffs now that are clinically graded, and they can actually work with movement. So the automated ones have gotten better, but it still doesn't hurt to be on a manual. Now, when you're doing a thing like a stress test or something like that, what you need to understand is that having those clinical grade Bluetooth ones will send signals and measurements every so often that you need them to, and they work a lot better because of the instant the instant data processing. But also, it's really hard to hear a manual blood pressure stethoscope when that person is moving on a treadmill, plus their arm is moving. It's very, very difficult. They have hybrid blood pressure techniques here, where you're gonna, the machine handles the inflation and the deflation, but you are listening to the sounds through the stethoscope. So it's a combination of electronic plus listening. So again, this one might be a little bit better, but I've never really worked with too many hybrid ones, but it doesn't mean that it's not available. But basically, it frees up your hands so that you can have a better stethoscope push so you can hear the sounds better. This is the problem, though, is that with manual, there's a lot of error. So how do we reduce the error? Follow these instructions. Proper cuff size, placement of the cuff, earpiece positioning. Sometimes not having it fully around your ear can cause different sounds to come in. Um, Allow undisturbed seated rest first. So you want that person to sit down, relax, not make so much movement, because that'll change up everything. Inflation, deflation can cause that. Where to position the pressure gauge, because then you can't see the right things. And then round to a previous even number. So when people say that you have a blood pressure reading from manual of 121 over 87, that's really not true, because the measurements are all taken in, on the sphygmomanometer, all the numbers from the pressure gauge are all in even numbers, so just be aware. So with heart rate, really, it says that one of the tricks here is just making sure that people sit for 5 minutes. That'll allow the heart to kind of calm down. You're in a neutral position. All right, you're lying down will give you a different heart rate reading. Standing up will give you another heart rate reading that's off. So you want to make sure that you can have a proper one. So have them seated for 5 minutes before they check it. You can use heart rate monitoring systems. You can, they may not be the most accurate. You can, auscultation. You can listen with a stethoscope. You can feel it with your fingertips. So there's a bunch of different, or you can, like an EKG actually can give you your, if you're on an EKG already, then, you can see the rhythmic motions, and you can determine how many heart rates you're getting, how many pulsations you're getting at that point. But one of the things that we have to understand, though, is, we put so much emphasis on resting heart rate, but resting heart rate is not equal to, it doesn't really mean that just because your resting heart rate is 47 that you have a really high quality cardiorespiratory fitness level. Okay, so that's one of the things that sometimes gets misconstrued. It just means that something else could be going on. That person could be on medication, any of it. Okay. For heart rate testing, I'm not going to go over this in detail, but you can read the information there. You can do it. My suggestion is always do it for 60 seconds, because it's the most accurate, because it's for that minute. Heart rate monitors are going to, they're going to be some error. All right. The one thing is it allows for freedom of movement, but if we're trying to check resting heart rate, then, we want them to stay still regardless. But at the same time, when we get up and move around, we can see the changes that occur at that point. So they, like it says here, they're pretty accurate versus an EKG. It's just, basically what it is the heart is the heart rate is being detected by, like it says there, electrodes. And what happens is when it's detected, it's basically detecting what's going on under the skin. And then what will also happen is that it sends a specific signal to the system, and the system is able to basically take what is being sent to it and rummage through all the data that it's getting, and then put it into this algorithm, or really long equation, so that can give you a heart rate that changes very often. All right, so with heart rates, there's a lot of things that can affect it. Stressors, medication, caffeine, when you have your caffeine, how much you're having. So that makes, time of day and body position. We kind of talked about how body position plays key. Lying down will give you the lowest. Standing up will give you the highest. Time of the day, depending upon the time of the day, when's the, resting is right as you wake up. All right, and then it it stays elevated for the rest of the day, even though even though it may not be as high, it's still going to be higher than resting, because you're moving around all day. There's fluctuations in hormones, enzymes, muscular contractions, things like that. And then meals can change your heart rate, and then smoking and drinking as well. One of the things, you see, this is for more assessment. We go over this in assessment class, but there is a 12 lead EKG that this could be something that you're gonna work with a GXT. So if you're gonna do a true stress test, you would be doing something like this. You're trying to find your depolarizations, your repolarizations. Are they properly in the P through T waves, and are they actually, are they showing any sort of arrhythmias that at that point? And so there's ways that you're supposed to set your electrodes up. We can go over that more in detail in class, but it's a 12 limb, it's a 12 lead, 10 electrode function. All right, and what basically is happening is those nodes are sending specific signals to each other to get the right transmission here. And now if you look, you'll see this is obviously an EKG readout. What I was saying about the P, QRST, this is one blip on that. So you're basically saying, okay, well, does that look abnormal? Okay, is this reversed? Is there no depolarization, or there's minimal depolarization? Is there not enough relaxation or repolarization? So we can determine that by each segment of the EKG. All right, and then so with node placement, what we're saying here is that you can see negative to negative, positive to positive, positive to negative, and those limb leads will give you those interactions with the heart. All right. So again, testing procedure wise, I'm not going to get into detail with this. You can read over that if you want to, but just making sure that everything's connected correctly and the right wire is going to the right electrode, and then make sure that they actually work. Okay. So this is just generalized assessment, nothing too crazy here. We're not getting into detail on cardio testing. We're not getting into muscle strength or endurance testing, because we've already gone through that with classes. So this is just preliminary health screenings, because this is going to be appropriate, even though it's for this is an assessment. This is still going to lead you into what you're supposed to be doing for your exercise programming, your exercise training sessions. All right. So chapter 2, we'll see you again for chapter 3.